Hello, and welcome to the Clinical Care Options Infectious Disease, Practicing Clinicians Exchange, and Pro-CE Pharmacy Practice podcasts. I'm your host, Sarah Anderson. This episode features content from an educational webinar titled 2023 Update, Practical Case Studies in Outpatient COVID-19 Management. During this podcast, Tracey Piparo, a physician associate in the Department of Palliative Medicine at RJWBarnabas in New Brunswick, New Jersey, and Dr. Renslow Sherer, professor of medicine at the University of Chicago in Chicago, Illinois, discuss the latest recommendations for risk stratifying and treating non-hospitalized patients with COVID-19 in the form of case discussions. To follow along with the accompanying slide set, please visit the link in the show notes for this episode. Now, let's get started and hear what Tracey Piparo and Renslow Sherer have to say about outpatient management of COVID-19.
Thanks to everybody for joining us. I'm going to talk about the principles behind the thinking for initiation of ambulatory therapy. So the first point is most important is identifying those folks who have risk factors for severe COVID. The large categories are older age, immune compromised, or multiple comorbidities, and we'll go into a little more detail on that. For those who fit that category, and then who have some degree of dyspnea, or if they have a home pulse ox and have a significant hypoxia, that is a group where we should really think seriously about referral to the emergency department for evaluation. And I just want to pause there for a moment that common sense really applies as we're thinking about COVID and when to send people to the emergency room. So certainly shortness of breath or known hypoxia would be sufficient reason. Lots of other reasons that COVID can cause a reason to go to the emergency room, like a cold limb, like severe substernal crushing chest pain for an MI, or evidence of an evolving stroke where an urgent intervention would be needed. The presence of a high fever that's unrelenting, abdominal pain that was severe that might be associated with a more severe abdominal problem like a clot or an embolus to the mesenteric artery, a seizure or altered mental status, particularly in an older individual, all would be reasons to think of an emergency room evaluation during which a COVID test could be done. So we're talking about folks who don't fit in that category. So those who have high risk, but who do not have shortness of breath, if they have a pulse ox, who have a normal oxygen level. And then the question is, if they have those risks, and have had symptoms for less than 5 days and don't have dyspnea or shortness of breath, they should be considered for the potential for antiviral therapy. And I want to just focus on that interval of 5 days. It's actually quite important because a couple of the antiretrovirals really are most effective if given within that first 5-day period. Intravenous remdesivir actually has an indication that goes out to 7 days. So let's talk a little bit more about the data, the evidence for this, and the nature of those risk factors. So this is a very useful diagram from one of the many cohort studies looking at the risk of death by age and then by select comorbidities. And the story that it tells, the graphic on the left, is as you go up in 10-year increments over age 40, you can see there's a gradual increase in risk, and it really accelerates over age 50 with a 4.3-fold increased risk of hospitalization and death. Past that, age 65 to 74, a 6-fold increase, an 8-fold increase for 75 to 84. 10-fold increase for those who are over 85 at present. And I'm sure you all know that there's still ongoing morbidity and mortality from COVID at the present time in the United States, and that 80% of people who are dying now from COVID-19 are over age 80. So it clearly is, age is by far the strongest predictor for morbidity and mortality. And anyone over age 50, I think, should be considered as potentially eligible for therapy, and particularly those with comorbidities. That's the second part of the story. So that includes people with diabetes, with chronic kidney disease, with COPD, with neurocognitive disorders, with cardiovascular disease. And you can see each of those were significantly at greater risk than younger people without those comorbidities. And then if you look in the EPIC-HR study, there were actually quite a few additional categories for substantial comorbidity. Add to that sickle cell disease, for example, anyone with active or past cancer, tobacco smoking, technologic dependence, interestingly, and I'll go on because it's really a useful list to think broadly about. Just people who are sedentary, who have physical inactivity, are at greater risk. Current and former smokers, as I mentioned. I think pregnancy is an important addition to that list, current or recent. Anyone with tuberculosis, anyone with substance use disorder, anyone with mental health conditions, particularly depression and schizophrenia, a wide range of immunocompromised, recent transplant recipients, bone marrow or solid organ transplant, distant transplant recipients, people with HIV infection, and particularly among that category, those who have advanced or untreated disease, people with dementia. So it's quite a long list, and I think it's reasonable for clinicians to think broadly and expansively about eligibility for antiviral therapy based on that list. So the current NIH treatment guidelines have recommended and alternative therapies in their recommendations. The recommended treatments are either nirmatrelvir plus ritonavir, that's 3 pills orally twice a day for 5 days, or remdesivir, which is an intravenous medication for daily for 3 days. And as you can imagine, that takes some logistic organization. You need an infusion center or the capacity to do that in your clinic or your hospital or your emergency room. The indications, as you see, are largely for individuals age 12 and over. Those on nirmatrelvir and ritonavir, it's weighing over 40 kilograms. And as I mentioned before, for the nirmatrelvir, it has to be used within 5 days of symptom onset for best benefit, though I would say there's some evidence of ongoing benefit up to a little bit longer period, and one could consider that. There is a renal dosing available for nirmatrelvir ritonavir in the setting where glomerular filtration rate is between 30 and 59. For remdesivir, it can be used within 7 days of symptom onset, but it does require that infrastructure. There's also a hierarchy of benefit for oral antiviral therapy for outpatients with mild to moderate disease. Clearly, unvaccinated patients benefit the most from these therapies, but the majority of them are being used now in vaccinated patients, both partly vaccinated patients and even those who are fully vaccinated in the setting of additional risk because of age, immune compromise, or comorbidities. The alternative treatment that's offered in the event that there's no access or reasons that you can't use the IV remdesivir or the oral nirmatrelvir ritonavir option, and that's oral molnupiravir, which is tablet every 12 hours for 5 days. It's restricted to only people who are age 18 or over. It also is most effective and should only be used within 5 days of symptom onset. It has a substantially lower efficacy in clinical trials in the range of 30%, and that's why it's listed as an alternative only if you can't get the other two. It also is potentially teratogenic, so it should not be used in pregnancy under any circumstances. That's a strong contraindication. And it should be used with caution in women of childbearing potential, essentially effectively guaranteeing that there's adequate contraception during the time of use. So I think an important advance in recognition of the emergency status of COVID as these therapies became available was this FDA authorization for pharmacists themselves to directly provide nirmatrelvir ritonavir to eligible patients. So meaning you can go to your local pharmacy and say, I've got this positive test and I'm having these mild symptoms, but I'm at risk for my age or for my comorbidity. And once a pharmacist is able to take the steps that a clinician would take, which is they may have access to your medical record and know of kidney and liver function, also have access to the medications that you're taking to search for potential drug interactions. But the vast majority of patients, these are manageable issues and they can go ahead and receive therapy. And in the event that the pharmacist doesn't have all the information they need, they can refer an individual to an authorized prescriber. This is a really important time to just recognize that even though the emergency nature of COVID is being relaxed in the United States, it's not gone, and we still have lots of reasons to consider it, to think about testing in a timely way. So I still think having home rapid tests is a very useful strategy when people are symptomatic, if you're anticipating taking a long trip, if you have new symptoms that are unexplained. So it's still a very important time to do the home rapid test or to seek a PCR for a definitive answer, and to do that in a timely way. So I would encourage you, if you think I've got a new sore throat, or I'm having a cough and an upper respiratory infection, I want to make sure that this is or is not COVID, so I could take the steps of accessing therapy. And I'll reinforce that message and anticipate a little bit of the later part of this talk, just by saying that symptom reduction is also associated with the use of these antiviral therapies. So not only are you going to reduce the potential time for shedding of the virus for a public health advantage, but your patient or you yourself will feel better within the first 24 to 48 hours with a reduction of symptoms. There's also some evidence that the use of antiviral therapies can reduce the incidence and severity of long COVID, which is now becoming a major public health threat in the United States. So these are the data. There's several different iterations. This is from CDC on the risk of SARS-CoV-2 for hospitalization, death by race and ethnicity. And it just calls attention to the fact that I think we're already very aware of in this country, that increasingly vulnerable groups, social groups, and groups by race and ethnicity are at higher risk, both of incident infections, as you can see here, 1.5-fold greater incidence among Native Americans, among Latino and Latina Americans, and also hospitalizations occurring at 2-fold or greater likelihood among African Americans, Latino, Latina, and Native Americans, and a greater risk of mortality. For all these reasons, there's an urgency, I think, in reaching these populations by message, by availability of testing. And we've seen that these health inequities can actually be associated with the social determinants of health, with issues around housing inequity, food insecurity, economic opportunity and its lack, and racism in the United States. So it's an urgent matter, I think, to address this in a variety of different ways. Accessing therapy to SARS-CoV-2 is one of them. So in terms of the health inequity of just access to therapy, the first principles are to improve communication and patient education, improved access to testing, for example, through local pharmacies as well as health providers, and the use of home tests, I think, is important. It's important that state and local governments and the federal government have made tests available at no cost, for example, to Medicare and Medicaid recipients, and to take advantage of the telephone, of social media, of telehealth as a way of communicating with patients. So I'll always tell my patients to contact me directly if they have an upper respiratory infection, they're not sure if it's COVID or not. We can talk it through, and I'll encourage them to test themselves so that they will know if they are a health risk to immunocompromised or elderly patients in their family, but also if they themselves should access antiviral therapy. So with that, I'm going to stop and hand over to Tracey. Welcome, Tracey.
Hi, Dr. Sherer. Great to be here today. We did have one interesting question come in related to what you just went over. Can you initiate antiviral treatment based on symptoms only, or do you really need to have a positive COVID test? I think that's a good question, because we are talking about, the importance of early testing.
Early testing is important. The fact that you can do these tests so quickly and have an answer in 15 minutes really means that I do take someone's history and say, let's do a test and find out for sure, and try to make that available as easily as possible. The one exception, I think, Adele, that I would take into consideration is the sudden presence of anosmia, meaning not only do I have flu-like symptoms, but I can't smell or I can't taste, or everything tastes funny, because that's such a harbinger of SARS-CoV-2 infection. Otherwise, I personally strongly prefer a positive test, because there's a lot of, as we've heard, respiratory syncytial virus out there and influenza, and I would prefer not to use medications without some level of confirmation. If that happened actually in that setting and there was anosmia and a very characteristic clinical history, and then the rapid test was negative, we know that those tests are not foolproof, and I might elect in an individual patient to treat. The same is true for the enabling of for pharmacists to prescribe. While it's recommended that there be a proven positive test, they are able to offer treatment on the basis of symptoms. But I think it's a bad habit, and I just want to reinforce that because there's so many colds and flus and variety of different symptoms that mimic COVIDs. I want to just make an example from my own experience. Our own emergency room has been very involved in incorporating HIV screening into every visit into the emergency room as appropriate for clinical signs and symptoms. We had a whole handful of patients who were thought to have who thought they might have acute HIV or who might have COVID, who came in who actually ended up testing positively for HIV and not for COVID, for SARS-CoV-2. So I think it's best practice if we encourage people to get that answer for themselves using a rapid antigen test or a PCR.
Good. I think that's good to know. So we're going to move on to some practical cases. And I'm sure as we go through these, you guys are going to think, I've seen that patient before. So I think this information that we have presented here is super useful. So our first case is a younger person with no comorbidities. She's a 32-year-old female who's a health profession student and really no contributing past medical history. She just takes ibuprofen as needed. She admits that she is sexually active with a male partner and does use condoms for contraception. She has been fully vaccinated with the mRNA primary series as well as all the available boosters. She tells you she has some cough, a subjective fever, and fatigue, and that's been lasting the past 3 days. She says, I did my at-home rapid antigen test and it's positive, so now what do I do? Well, we're going to go back to that decision tree that Dr. Sherer went over a little bit earlier, and we know from her what we're being told of her history, does she have risk factors for severe disease? And we're going to say no. And does she have moderate or severe dyspnea or hypoxia? We're also going to say no to that. So according to this, we're going to follow our decision making of no COVID-19 specific treatment is necessary. She needs symptomatic management, which we have all been doing for years for the various viral things that are out there. And it's important to schedule telehealth follow-up for these folks because we want to make sure that the symptoms are resolving. She should start feeling better. So remember, we're going to now talk about the same patient, except she now tells you that she's 24 weeks pregnant. She's taking a prenatal vitamin. Of course, she is sexually active with her male partner, still has all of her primary vaccine series and boosters, only having symptoms for 3 days, and she's positive for COVID on her rapid antigen at home. How does this change your approach to the patient? Think about that for a little bit. As we know from going through the prior slides with Dr. Sherer, that pregnancy is a risk factor. And we're going to throw another different patient in there and say you have the same woman, but now she has type 1 diabetes and she's on an insulin pump. Rest of her presentation is the same, still only has symptoms for 3 days, and her home rapid antigen is positive. So how does that change your approach to the patient now? And we're going to go back to that decision tree. I think this is super useful, even clinically, just to have the way this is laid out in your mind. And we're going to say, are there risk factors for severe disease? For both of those patients, we now have to say yes. One is pregnant and the other one has type 1 diabetes, which we know are inherently risk factors for severe disease. Do they have moderate or severe dyspnea or any hypoxia? No. So now we have to ask ourselves, how long have those symptoms been around? Have they been around for less than 5 days? Yes, because it's only been 3 days as reported by the patient. So we're going to get down to the bottom of that tree there and consider COVID-19 oral antiviral. And we're going to talk a little bit about that in a little bit. And remember too, we're going to schedule telehealth follow-up with these people because we want to make sure that their symptoms are resolving and they haven't developed any new symptoms that need to be addressed. And we're going to start moving on to another case too with Dr. Sherer, but I think that there are some questions coming in that you want to go over some of them, Dr. Sherer?
Sure. Would you treat someone if they are a direct close COVID contact and they got some symptoms, but their rapid test is negative? What do you think?
I think it's kind of like what we spoke about before, that it does get kind of touchy there, that if they're having lots of those symptoms, but that test is negative, but we're worried, especially if they're high risk, whether we treat them or not. But there are so many other circulating viruses going around, as we all know. I think that is the reason why we have the option for retesting, watchful waiting and retesting in 2 or 3 days, where you may still be in that window for the oral antiviral if necessary. I don't know how you feel about that, Dr. Sherer.
No, I think retesting in a couple days is the right answer. I think it's better to go in that direction than to using, treating just on the basis of symptoms alone, because there's so much overlap. There's another question. How many days of self-isolation is recommended after a test is COVID positive? So I think we're in the same era with the CDC general guidelines for 5 days of isolation. And if people are in your environment, then wearing a mask during that time. And then 5 days back out in the world, but using a mask for protection. And these are important as we have all become, annoyed with SARS-CoV-2 and wanting COVID to be over. I think it's important to be respectful still of those general recommendations that a positive test and symptomatic and evidence of disease means you need to take yourself out of circulation for 5 days and then wear a mask for another 5 days. And there's one more, Tracey, you might want to take on. It's in regards to anticoagulant coverage with COVID. I remember treating young people with TIA, with a TIA and myocardial infarction due to inflammatory processes. And now I do see older patients who have COVID but are not given anticoagulation. So I think the general question here, Tracey, is there any role for anticoagulation therapy as part of outpatient management of SARS-CoV-2?
Yeah, I think, outpatient for, the folks who were not sick enough to and be hospitalized, I haven't seen much anticoagulation being given. Early on in the pandemic, those hospitalized folks that were pretty sick, we were treating with anticoagulants, whether it be aspirin or even things like apixaban to cover them. I think that kind of waned off as the virus mutated a little bit and we moved on in the variants. I don't think we've seen as much hypercoagulability, but I don't know what you've seen in your practice, Dr. Sherer. I know it's not standard where I am right now. I agree, that we've kind of seen that kind of fall off.
Well, sure. Well, I would say we're definitely not addressing hospitalized patients with COVID in this call, and there still are people being admitted with acute symptoms that would fit with a transient ischemic attack, like fleeting loss of vision or a sudden hemiparesis, severe neurologic signs and symptoms. That person should go to an emergency room, should be admitted to the hospital. And honestly, the management of that individual in hospital will vary depending on the specific signs and symptoms. They may end up with angiography. There are a variety of tools for someone with a short-term evolving stroke, if that's what that turns out to be, that include thrombolytic therapy, a variety of different responses. Some of the data shows that anticoagulation in all people with severe SARS-CoV-2 has benefits, that it can reduce the incidence of severe outcomes, but it's a little more mixed, and so it's beyond the scope of this particular call. But it's a well-informed question, so I appreciate that. But this is always the discussion around that CDC recommendation for 5 days. Is the 5-day quarantine from the date of first symptoms or from the date of the diagnosis? From the date of symptom onset is correct. Oftentimes, you may have mild or no symptoms, in which case it's the date of the test. Yeah. I'm going to take patient case 2. This is a patient with immunocompromise, a 62-year-old male with polycystic kidney disease, had a kidney transplant in 2015, doing well, now on low-dose tacrolimus, with a BMI of 26, hypertension, type 2 diabetes. This individual is fully vaccinated, has had all indicated boosters, has got new symptoms of COVID-19, which you mean is an influenza-like illness. So the initial symptom presentation has a slight subjective fever. It's now 12 hours later. This is the third day of symptoms. He has fever, cough, sore throat. He is not hypoxic. He's not short of breath. And on the right is the list of medications: tacrolimus, metformin, magnesium oxide, vitamin D, olmesartan, and hydrochlorothiazide. And indeed, he tests positive for his COVID PCR test. So I'm only repeating the list that we went through in order to say this patient meets criteria on several grounds, for chronic kidney disease, for diabetes, for his transplant and immunocompromised status, his being overweight. So there's really no question that he fits with as someone who has serious comorbidity, who is not currently dyspneic or having severe hypoxia. So he is clearly a candidate for antiviral therapy. So the transplant team looked at his current medications. They looked at the considerations for antiviral therapy, and they thought that the tacrolimus and the drug interaction potential was concerning. And so they thought that one of the two other options might be a better option, IV remdesivir or oral molnupiravir. And to inform this, their clinical pharmacist went to the Liverpool website and looked up the recommendations for nirmatrelvir, ritonavir, and tacrolimus, and it was to not co-administer. Interestingly, there are other options. The NIH guidelines also say another option would be if it was thought that the patient was stable enough to hold the dose of tacrolimus during the course of therapy with nirmatrelvir, ritonavir. But in this setting, that was the decision that was made. So that brings us to our next patient.
We're going to get to patient number 3. We're now talking about an older adult with some comorbidities. So as you can read, this is a 75-year-old female. She has hypertension, type 2 diabetes, chronic kidney disease with a GFR of 47, and is currently being treated for AFib. She presents with 2 days of cough, shortness of breath, and fatigue. She is fully vaccinated and boosted with the mRNA vaccine, and she tests positive today. We look at her medications and we realize that she, among other ones, is on apixaban, 5 milligrams, which she takes BID. We get a little bit more information about the patient, and you can see some of her vital signs there, as well as her lab work. Again, her renal function going along with her GFR of 47. And we're going to think back to that decision tree that we have, and does she have risk factors for severe disease? And of course, we know she does, because number 1 is her age, and number 2, she's got multiple comorbidities that we're worried about, and that includes her CKD, diabetes, hypertension, and cardiac disease. So a clinical pharmacist reviews the management algorithm and decides that the patient does qualify for nirmatrelvir and ritonavir, and assesses the drug-drug interactions, and recommends, knows that renal dosing is recommended if the GFR is between 30 and 59. And remember, this patient is at 47. I'm sure everyone is sitting there thinking about, we have to think about other drugs, and we highlighted apixaban there. So you're right. Remember, ritonavir is a CYP3A inhibitor, so it may increase the levels of other drugs. When used with CYP3A inducers, may not achieve adequate levels of notramavir. And that's when we go back to Liverpool, which is a great resource. And it tells us if treating atrial fibrillation with the standard dose of apixaban, which this patient was on, 5 milligrams BID, then the recommendation is to reduce the dose to 2.5 milligrams BID. So we know that we can treat this high-risk patient with her nirmatrelvir, ritonavir, but just tell her to decrease her dose of apixaban while she's taking the medication to 2.5 milligrams twice a day. So other thing we wanted to touch on is the role of the interprofessional team here when we're treating people in the outpatient realm for COVID. So just like Dr. Sherer was talking about pharmacists taking a role in providing these medications, the pharmacist also serves as a second check because they can also run comprehensive drug-drug interactions and can ensure that no medications are missed. So that's a valuable resource for patients and ourselves when we're prescribing these medications. Another thing that's super important, like I said, is to make sure that we're checking in with these patients after we prescribe medications. Maybe the clinic can set up a way that a nurse can check in with them 2 days after starting treatment, because you want to make sure that the symptoms are the same or improving. Nothing should be escalating after starting treatment. And then at some point, likely after treatment is completed, there should be a follow-up telehealth visit with the primary care physician with that patient, because honestly, they should be feeling better. And if they're not, we should be concerned that there's maybe a secondary thing going on. We're going to get to another patient case here. And this is now a patient who's going to warrant some further evaluation in an emergency department and maybe even admission. So as you can read in front of you, this is a 51-year-old male who has significant past medical history, including smoking, but he did quit 2 years ago, COPD, hypertension, and his BMI is 29. His medications include albuterol, tiotropium, lisinopril, and chlorthalidone. He is fully vaccinated with both his primary series and the boosters, and he presents saying that he has 3 days of a new cough, not related to his COPD, increased shortness of breath, increased wheezing, and lots of increased fatigue. He did take a test at home, and it was positive for COVID-19. You can see his vitals there. And of course, I think we would all, as clinicians, be a little concerned because his O2 saturation is noted to be 88% on room air. We're going to head back to that trusty decision tree, and we're going to say, does the patient have risk factors for severe disease? I think we all know, yes, of course he does. Does he have moderate or severe dyspnea or any hypoxia? We have to answer yes here. This is definitely different than our other patients that we were talking about, because at 88% on room air, he definitely has hypoxia. So we're going to refer him to the ED for evaluation. I know a lot of folks were asking some questions about close contacts and those with COVID-19, and I think this is something that we all get asked pretty frequently. So we want to make sure we're always protecting others, and I think we've talked a lot about this. So as Dr. Sherer had said, the CDC guidelines, it tests positive for COVID, you want to quarantine for 5 days. And your close contacts, if they're not up to date with the COVID-19 vaccine or have not had COVID in the past 90 days, to protect people should quarantine for 5 days and avoid travel through day 10. And you should be wearing a mask around others for up to 10 days and be monitoring yourself for any COVID-19 symptoms for up to 10 days post your close contact. As far as testing, current recommendations are saying test on or after day 5 post-exposure, or at any time if you have symptoms. So if you've been in close contact with a patient who is positive for COVID-19, a family member, a friend, and you develop symptoms at any time, you should be taking a test yourself. The earlier, the better. If you do take a test and it's negative, the recommendation is to wear a mask in public and while traveling through day 10. If you're positive or symptomatic at any time, you should isolate away from others for 5 days and not travel for 10 days. So, if at any time you become positive, you're going to default back to following those recommendations for someone who has tested positive for COVID. Remember, early diagnosis by the rapid antigen test or PCR is really essential for outpatient care of COVID-19. Symptoms and risk stratification do determine the eligibility for treatment of selected ambulatory patients. Remember, any patients who are immunocompromised are going to require some consultation with other folks. So just keep that in the back of your mind. Guideline preferred effective treatments that we have available right now include antivirals nirmatrelvir and ritonavir, as well as remdesivir. Antiviral treatment within 5 days of symptoms is associated with optimal outcomes. There's no way to get around that. We know that if these folks are treated within 5 days of their symptoms starting, they're just having better outcomes overall. Drug interactions and dosing requirements do require some attention, but remember, that's why we want to lean on our colleagues and that sense of having an interprofessional team, because we're going to have those pharmacists that are able to second check that for us. Alternative treatment options is the antiviral molnupiravir. Don't forget that that also is available when necessary. An interdisciplinary team is very beneficial for care and support of all patients. I think that's the most important, is to remember that we all have a role to work together here and really help people get the best treatment that they can. And I know that there's some questions coming in there, Dr. Sherer.
Yeah, we've got a bunch of them. I'll take a couple and then toss them back to you, Tracey. So what is the renal dose of nirmatrelvir ritonavir? And instead of the 2 pills plus 1 ritonavir twice a day, it's 1 pill. So instead of 300 milligrams nirmatrelvir ritonavir, it's 150 plus 100 milligrams of ritonavir twice a day. So basically half the dose of the nirmatrelvir for people in that category. With the reports of long COVID, even following people with mild disease, should we treat people with milder disease? We've actually been talking about treating people at high risk with milder disease. What do you think?
Yeah, I mean, I think there's probably going to be some thoughts about that or some research about that. You may know better than me, but I'm not sure. I think the most important thing to really focus on is cutting down on the mortality right now and the morbidity, which we're definitely seeing more in those high-risk patients. It really does seem that the folks without high risk are recovering. And even those with long COVID, from the things that I've seen, the symptoms are getting better. It's essentially, they are taking longer, and no one likes to be patients. So I know that that's difficult, but I'm not sure if there'll be something in the very near future where they do recommend, treatment for anyone who is positive.
Yeah, I agree with what you're saying. We're really talking about people who are positive, test positive, but who have mild to symptoms altogether, who are at high risk, older age, or with comorbidities. I wouldn't expand even because we're seeing long COVID in a younger age population yet. That is an important research question, but I agree, we don't have the information on which to base therapy like that now. Well, what if somebody's already on anticoagulation? How, for example, apixaban, how should they be dose altered? And the answer to that actually varies depending on the specific anticoagulant that they're on. And so that would be a case by case depending on the drug. We've already talked about the apixaban interaction. And for many clinicians, that might be a reason to another moment where you would say, I don't really like those drug interactions. I will choose an equally effective intervention that does not have those drug interactions, using 3 days of IV remdesivir. And someone else had said, shouldn't we always use the nirmatrelvir because it's more effective than remdesivir? But if you remember from the registrational trials, the likelihood of preventing hospitalization with nirmatrelvir and with 3 days of IV remdesivir was over 80% and very comparable between the two. So the anticoagulation category in terms of their interaction with nirmatrelvir is a little complicated. Some have no substantial interaction or need minor dose alteration, and then some are contraindicated. So the most important thing as a clinician is to remember drug interactions are important, and you want to check it before you go ahead with any one of these individual drugs.
Yeah, that's a good point.
For you, Tracey, another question. People who have been asking me about both zinc and vitamin D as potential therapies or adjuvants, and also the role of metformin in managing ambulatory people with high risk who have COVID positive tests.
Yeah, I mean, I probably may not be the best person to comment on zinc and vitamin D, but I know that, recent recommendations from NIH is, there is absolutely no recommendation for metformin at this time. We had actually spoken about this, I think, in a prior webinar. Folks who are on metformin for their type 2 diabetes or any other issue is fine to continue their metformin and be monitored, but there's no indication for treating with metformin just because of a positive test for COVID.
Good. I'll add the same comments that there's no evidence that the addition of zinc or vitamin D to a regimen for someone who has mild to moderate SARS-CoV-2 infection has any impact on outcomes. And so I I wouldn't recommend it. There's a question which is, have you seen rebound COVID symptoms post-treatment? And we have. It occurs anywhere from 5 to 15% of the time. It occurs actually with each of the different antiviral therapies. Importantly, it's not just nirmatrelvir. It also occurs with remdesivir and with molnupiravir. And this is really important. It's also in a large study that just looked at this. It's seen in about 30% of people who are not treated, meaning that the disease itself waxes and wanes, and you see people starting to feel better and have more energy and then seeming to relapse or rebound with symptoms. Some of those people, about 15%, rebound with actual viremia and are again infectious. And what's interesting is about 30% of people rebound with symptoms who are untreated, about 15% rebound with viremia, and only 3% of those two groups actually overlap, have both symptom relapse and active infectious viremia. The problem for us as clinicians is we have to advise all of our patients when they relapse with symptoms, or if they are found, if they retest themselves, if they're still positive, to behave as though they're still potentially infectious, to stay home, isolate for another 5 days, and then wear a mask for another 5 days thereafter, even though some portion of those folks will have a positive test, but will actually be inactivated virus and they will no longer be infectious. But because of that 3%, we have to let everybody know that they may potentially be infectious. And I'm sure you've been dealing with this in your practice, Tracey, with rebound COVID. How do you talk to patients about it?
Yeah, I think very similar to what you were saying. I actually just had this a few days ago. I think more is that it's kind of mentally upsetting for patients. You know, they feel better, they test positive, they do the right thing, they get the antiviral medication, and they start feeling better. And they may have a period where they are much improved, and then they feel like crap again. And it's kind of like you said, if you retest and you're still positive, it's that having to isolate yourself again and, you know, mask and keep yourself away from family and just generalize things in life. But I think that's the important part of making sure that we as clinicians follow up with these folks to make sure that they know what's going on. It's a known phenomenon. It's, of course, nobody's happy when it happens, but we also, you know, have to protect the other people that are around us. So if they do have those rebound symptoms and retest positive, we have to assume that they would be infectious again and restart that clock. So I agree with you. It's just something that happens, but we have to be there to support them through it. I think there's another good question here that says, you know, I just want to hear what you think about this patient, 62 years old with 2 days of nasal congestion and rhinitis and a very mild cough. No dyspnea, hypoxia, or fever, no other risk factors or comorbidities, fully vaccinated. Well, my question is, if the patient is COVID positive, then they are definitely considered high risk at this point because of their age alone. So I would recommend that if their symptoms have only been for 2 days, that they get treated with an antiviral. The question is whether we should recommend testing at all. I would, because there's no harm in testing, again, just to make sure that if you are positive, you want to isolate, you know, away from folks. At 2 days, if the patient is negative for COVID, but continues to have symptoms, I probably would recommend that they retest themselves in 3 days. And then we're kind of on that cusp of the 5 days where if they were positive, since they would be considered high risk, we could in fact start an antiviral. I don't know if you have anything else to add, Dr. Sherer.
No, I completely agree, Tracey. I think you handled that one exactly right. If that patient that he's describing is known to have just tested positive for COVID, yeah, then I think treatment is indicated with an antiviral, and as we've talked about on this call. There's another question saying that you said that patients with substance abuse should receive treatment, but what about a recovered alcoholic who hasn't drank for 10 years or more? And that's a great question. I would agree that we're talking about active alcoholism, active substance use, as distinguished from a history of past drug use. So I think that's really important. Another question for you, Tracey. What if someone comes in on warfarin is known to have a positive test is a candidate for antiviral therapy, what would you recommend?
Yeah, definitely. I'm assuming, on warfarin, they definitely have some comorbidities going on. They probably fit the age criteria, not necessarily. So I would definitely recommend antivirals. They probably are on multiple other medications besides just the warfarin. So again, leaning on our interprofessional team and doing those cross checks with medications to make sure that there are no interactions so that we dose appropriately, I think is important. And, explaining what has to happen to the patient. And again, that follow-up is super important so that we make sure that people are actually feeling better.
Certainly people on warfarin tend to have or should have regular follow-up interaction and levels
Right.
taken. So it's on the use with caution list in the NIH guidelines. Warfarin is that for
Right.
in combination with nirmatrelvir, ritonavir. So that would be one option. Another would be if it's available, the 3 days of intravenous remdesivir. So that's an individual decision, but it certainly would not be a contraindication to therapy.
Yeah, I think that's an important distinction when we talk about the meds that are on that list to use with caution. I think a lot of us as clinicians get scared, but it doesn't mean don't use it. It just means, again, lean on your resources and know why the caution is there. But, it doesn't mean not to treat people, and also use your alternatives if necessary. Like you said, the remdesivir, for some places in some parts of this country, it may be much easier for folks to access remdesivir for their patients. I know near me, it's not as easy anymore. And really, it's only the inpatients that are getting it. So if the patient is doing well enough to be outpatient, I probably wouldn't have the capacity to give them remdesivir. But, it's that follow-up that is important. I know there could be an issue because of a warfarin. So it's that constant, contact with the patient, which doesn't always mean us particularly. Maybe there's another setup in the office where a nurse is checking in on them. But I think that's an important mechanism there to help out with those things.
There's another question, which I think is a really key topic to address. What is your recommendation for 5 to 10 days of steroids? And what about nasal steroids? And this is a good example of where clinical trials are so important. Surprisingly, in the large UK recovery series, the use of steroids in people with mild disease, non-hospitalized ambulatory patients, was actually associated with a worse outcome. And so they're contraindicated in the patient population we've been talking about. There's no role for prednisone or any other form of oral steroids for mild COVID, and it actually makes people worse. There has been sort of some interesting research that suggested that one form of nasal steroid might be associated with a reduction in the incidence of hospitalization from SARS-CoV-2, but that's not been replicated. So there's no known benefit from nasal steroids. They're not recommended as part of the initial therapy. If somebody is taking nasal steroids for other reasons, there's no contraindication to their continuing use. But I think there's not a role for active treatment of SARS-CoV-2 infection in people with mild disease who have comorbidities.
Yeah, I think this is a good question too. Talking again about rebound. So if you have a patient, from what I'm understanding her question, have a patient who tested positive, received antiviral treatment, let's say nirmatrelvir, ritonavir, and then did develop those rebound symptoms and test positive again, should they be retreated with the antiviral on their second positive test?
Yeah, the honest answer is we don't have any evidence that they should be. That's a clinical trial that is actually ongoing that we're enrolling people in here at University of Chicago. So the answer is no. At the moment, there's no indication for repeating therapy in people who have rebound. The most important point, this is true in both untreated and in treated people, is that the vast majority of those patients, when they have rebound, it's relatively short-lived. They go on to recover fully. So there doesn't seem to be a strong indication for repeat therapy, but it certainly would be interesting to know if that's a group that might benefit either from retreatment or a somewhat more prolonged period of time. And the likely answer here is that those folks who are having rebound in the bell-shaped curve of the total population of people who get infected are those who have a higher viral burden, a larger amount to clear to begin with than other people who are infected with SARS-CoV-2. So the answer is no, I wouldn't retreat. I'll take as a separate case somebody who comes in and says, last November, I had SARS-CoV-2, I had COVID, I was down for 3 weeks, I was pretty sick, and then I got better. Here I am again now, symptomatic, and I find that I have another infection. That would not preclude my using an antiviral for this same patient now. So you certainly can have people who've had multiple courses of oral antivirals if they indeed have had separate instances of reinfections with SARS-CoV-2.
Yeah, that makes sense. There's another question here saying, if you have an elderly patient with COVID who is positive for COVID and has had diarrhea along with that, and I know we were seeing that with some of the prior variants, but the diarrhea doesn't improve after 14 days. Do you need to be worried that the patient is still infectious even after they've been treated? And what other precautions may need to be taken?
Yeah, this is a tricky question. We have seen that viral persistence, that is prolonged infection past the average 2-week period, 10 days to 2 weeks, can occur. It appears in the vast minority of patients, but in one series, in particular of people with gastrointestinal involvement, there was prolonged shedding in stool, and that was in 4% of people, and that lasted actually for longer than a month. So there is the potential for ongoing shedding with infectious virus. It's a very small number of individuals. So we recommend following the CDC recommendations for relative safety because the vast majority of people, that's the case, meaning within 2 weeks, even if they tested positive thereafter, they would be shedding non-infectious virus. It's very difficult for me to give you a time frame with certainty. The nature of the patient would matter. So you mentioned elderly. It would be a more likely occurrence if they were over age 80 than if they were in the age 60 to 70 category. It would be a more likely occurrence if they were immune compromised because of cancer and chemotherapy or a transplant than if they otherwise were a healthier individual. But I can't put a number on it for you. It's part of the sort of the difficult part of the reality of SARS-CoV-2 infection. For a small percentage of people, you can have ongoing infectivity, in particular in the GI tract. And you heard me say it's 1 in 20 or fewer. That's the good news. It does seem to be involved in some of the pathogenesis of long COVID, though it really looks like long COVID has many different forms of creating long-term symptoms, and that's just one of them. So I'm sorry to not be able to give you a simple answer. COVID continues to bedevil us, and this is one of the ways that's most difficult for caregivers. If you can hear me saying it might be for caregivers for infection control, if they're in a long-term care facility or you're caring for that individual in your home, then I would be careful and consider that might be potentially infectious virus and work to clear up that individual's diarrhea in other ways.
Yeah, I think the most important thing is, to continue to take those precautions like we would, early on in the course. There's another question coming in. They have a patient who hasn't received the bivalent vaccine and they test COVID positive. Let's say they have mild symptoms and they recover. When then can the patient receive the bivalent vaccine?
We recommend that the vaccine be given 2 months after the occurrence of symptomatic infection. It's very interesting that the WHO this week has just come out with recommendations that for elderly or immune compromised, that there may be a reason to repeat vaccination at a 6 to 12 month interval, which seems to be the way we're going there. This is WHO recognizing that the impact of vaccination wanes after a 6-month period, and that may be a little sharper and more severe in the most elderly or the most immune compromised. We do think that natural immunity is associated with an acute infection, but that's also quite variable. It can go 2 to 3 months, as long as 6 months. But again, for those who are elderly or who have some degree of immunocompromise or multiple comorbidities, that's likely to be a lower response. And so a 2-month interval is reasonable.
I think that's good to know. There's another good question before we wrap things up here. And I think this may be a good one coming from your practice, Dr. Sherer. If patients have risk factors, let's say they're elderly with some comorbidities, and they would definitely be eligible for antivirals if they were to test positive for COVID, even with mild symptoms, and they're planning to travel outside the United States, is there any role for requesting antivirals before they leave, so that if they test positive while they're not in the United States, that they would be able to protect themselves?
Yeah, I actually have done this. And so I think it's a reasonable precaution. What I've asked the patients to do is to return the medication when they return if they've not had occasion to use it. But in the 2 times that I've done it, these were with, in both cases, people with advanced HIV who were stable, but who were otherwise, severely immune compromised. In both cases, they actually did get COVID while traveling, were able to sequester in their hotel room and take their medications with the prompt relief that it provides. So I think it's reasonable as a preventive practical tool.
That's great. I think that it's good for folks to know that they have that available so that they are protected when they're traveling. And I think these questions have been great. This has been awesome information to share with you guys. I want to thank Dr. Sherer and CCO, PCE, Pro CE for putting on this wonderful presentation.
I'd like to thank Tracey Piparo and Renslow Sherer for that excellent series of case discussions, and thank you to our listeners for joining in. As a reminder, to view the slide set for this podcast and the full program on best practices for early outpatient COVID-19 diagnosis and antiviral treatment on the Clinical Care Options Practicing Clinicians Exchange and Pro CE websites, click on the links in the show notes for this episode. And please be sure to check back regularly for more episodes on important infectious disease topics. Thank you.